So in PCOS, there is increased production of androgens from the ovary, as you can see here. DHEA sulfate levels are also increased. E2 is to E1 का ratio is 1:2 in PCOS, while in normal conditions, E2 is to E1 ratio is 2:1 in a normal female. But in a patient with PCOS, the ratio is reversed. Next is sex hormone binding globulin levels are also decreased in a PCOS patient. LH is to FSH ratio is equal to 2:1 or it can be 3:1, means the levels of LH are increased in a patient with PCOS. So what happens there is androgen is more. When androgen is more, that has a tendency to be folliculotoxic. So when it is folliculotoxic, there will be no ovulation leading to polycystic ovaries. Okay, so the next criteria that we are going to discuss here is the Rotterdam's criteria, which is also a diagnostic criteria for PCOS. So in Rotterdam's criteria, what we say, presence of any two of the following three. So three criteria, if any two are also present, we will say that the Rotterdam's criteria is fulfilled and the patient might have PCOS then. So what are these? Number one, when the testosterone level is increased, it will be number 1 point. Number two, when the patient has oligomenorrhea or secondary amenorrhea, when the patient is not having periods. Third is on ultrasound, if there are more than 12 follicles, 12 or more than 12 follicles of the size 2 to 9 millimeters in one or both the ovaries, or volume of each ovary is more than 10 ml. So if any two of these criteria are fulfilled, we will say that the patient has PCOS, and this is what is known as Rotterdam's criteria. Okay. So next is the USG appearance of PCOS ovaries. The appearance, USG appearance of PCOS ovaries, in which you can see this chain of legs appearance or something like a necklace appearance. So these little ones are the follicles. So they will be surrounding the ovary in the margins like this, as you can see in the diagram made by me. So this is an example of PCOS ovaries, right? Next is management. So first line management, when the patient comes to the OPD, first we always suggest them for lifestyle modifications. Okay, lifestyle modifications in the terms of, we'll ask patient to lose some weight, adapt a healthier lifestyle, exercise, moderate, and good eating habits. So these are some of the lifestyle modifications, and taking a proper sleep is also very important, which we suggest our patients, and to maintain a very stress-free lifestyle. If infertility is the problem, if patient has come to you with the problem of infertility, right? So weight loss, first we are going to suggest the patient if the patient has an overweight condition, and if that is present, right? So if if the patient is overweight, we'll suggest them for weight loss. Okay, the next line of management after weight loss will be supplementation of folic acid. Folic acid will be supplemented, and we'll ask the patient to try for natural conception, right? And if natural conception is also not working, then we'll take the patient on drugs. So first is lifestyle modification only in that case also. And if the patient is trying to conceive, we'll also suggest them to take folic acid along. Okay, so the drugs may, first line is letrozole. Second is clomiphene citrate. Third is HMG. If HMG is not working, then we'll switch to pulsatile GnRH. If pulsatile GnRH is also not working, then we are going to add metformin along with it. Okay, so these are some of the drugs, but the first line is letrozole only. Next is surgery is not preferred very well, but there are options available such as laparoscopic ovarian drilling, and in which the stroma is actually burned and the theca cells are destroyed. So this is a very short description of PCOS. I hope you are able to cover up along with me, and if there are any doubts, you can mention that in the comment section. Thank you.